Hi, good evening, everybody, and welcome to the first journal club for the Multimodality Imaging Group of Emirates Cardiac Society. I'm Dr. Juwairiya Al Ali. I'm the president of Emirates Cardiac Society, and it gives me great pleasure to welcome you to this first of the series of journal clubs tackling the most interesting articles and trials that came in the era of multimodality imaging. Our first journal club addresses a very important trial that came out this year. Lots of people were very surprised with the results, and lots of people were confused. So I'm sure you're going to gain a lot of benefit from our speaker and our discussant because we have an imager and an interventionist on the board here. So our speaker is Dr. Faraz Al-Badarian. So he's the head of the Imaging Working Group of Emirates Cardiac Society. He's an associate professor at Khalifa University, and he is a cardiovascular imager and a researcher at Cleveland Clinic, Abu Dhabi. So he'll be walking us through the trial and from an imager perspective. And then we will have Dr. Nadeem Shah, who is an interventional cardiologist at Rashid Hospital, who will give us his input as an interventionist regarding this trial. I would encourage you all to submit your questions as early as possible so we can get them answered at the discussion at the end. And I'm sure you're going to gain a lot of insight from this session. So without further delay, I'll give it over to Dr. Faraz Al-Badarian to talk about this very interesting trial.
Thank you so much, Dr. Juwairiya, and thank you for the Emirates Cardiac Society for their support in creating this platform where we can discuss recent and relevant journal articles that are likely to stir controversy or cause changes in clinical practice. And today we're going to experience a different flavor of these multimodality and multidisciplinary discussions. I'd also like to thank Dr. Nadeem for joining us tonight. I'm going to go ahead and share my slides. Can you guys see my slides?
Not yet. Yes, now it's starting.
Okay.
Yes, we see you.
Okay, fantastic. So the article that we're going to discuss is the revived BCIS study that was recently presented at the European Society of Cardiology meeting and was simultaneously published in the New England Journal of Medicine, and discusses a very relevant and clinically pertinent question, as Dr. Juwairiya has mentioned. I have no relevant financial disclosures for this discussion, but I want to emphasize at the beginning that this discussion is applicable to chronic stable ischemic heart disease. And at no point we are going to make inferences or discuss implications on the management of acute coronary syndrome, which is a completely different pathophysiological syndrome from chronic stable ischemic heart disease. I just want to make sure this is emphasized throughout the presentation to make sure that we are delivering the correct message throughout. Let me start off by a case that we took care of at our hospital. This is a 59-year-old male with prior coronary artery disease, prior PCI to the LAD, was admitted to the hospital with congestive heart failure. He has been having progressive shortness of breath, no angina, but it's mainly heart failure symptoms for a few weeks, increase in weight, lower extremity edema. He has diabetes and hypertension, and on presentation, his troponin was only borderline elevated at 0.03, and his BNP was in the 4,000 range. We started off with an echocardiogram that showed LV systolic dysfunction, predominantly affecting the posterior and lateral walls. His ejection fraction was calculated to be in the range of 32%. As you can see in this parasternal long axis, the anteroseptal segments are preserved in function and morphology. There is hypokinesis of the posterior wall. And on the short axis, these findings are further corroborated with a lateral wall hypokinesis. Myocardial thickness was preserved throughout, but because of his history of coronary artery disease, he proceeded with a coronary angiogram, which showed a patent stent in the LAD, severe disease in the mid segment, overall small caliber vessels, an occluded circumflex artery, and also showed a severe disease in the mid segment of the right coronary artery. At that point in time, as we do in all cases, we had a multidisciplinary discussion, and we thought that additional information is needed to understand the chronicity of this presentation. So the patient proceeded with a cardiac MRI with gadolinium, which I'm showing representative still images of the late enhancement images, where I show gadolinium uptake in the basal inferior wall, throughout the lateral wall, and the anterolateral wall as well. The uptake of gadolinium is extensive, involving more than 50% of the thickness of the myocardium in the affected segments, in basal inferior and anterolateral. These findings were presented again to the multidisciplinary heart team, and we felt because of the quality of his targets, the viability findings, we have felt, or the team felt, that the patient is less likely to benefit from CABG. Medical therapy needed to be optimized, and they recommended PCI to the LAD. Now, at that point, I can tell you there was significant discussion and debate among the team members of where is the benefit, where is the data, or where's the evidence that PCI in ischemic cardiomyopathy or a situation like this is actually advantageous and helpful for these patients. So this concept of myocardial hibernation, or the interaction between ischemia and LV dysfunction, is not a new concept. It's been described at least 2 or 3 decades ago by Rahimtullah in multiple publications, and he was really instrumental in advancing this concept of hibernating myocardium, which in a nutshell, it describes the differential response of the ventricular myocardium to acute versus chronic ischemia, and hence the two distinct syndromes of stunning and hibernation being defined as the chronic maladaptive response to reduced myocardial oxygen delivery that will lead to a reduction in LV systolic function. The benefit from revascularization is also different based on the chronicity of ischemia and the timing of revascularization. So if you revascularize a stunned myocardium, there is more rapid recovery. Whereas if you achieve myocardial revascularization in patients with hibernating myocardium, you want to make sure that you do it also in a timely fashion before ventricular remodeling is advanced, and the chances for recovery of function are diminished. And on a conceptual level, some of you may have seen this before, but it's important to go back to the basics. And what do we achieve when we perform revascularization in heart failure patients? First of all, we treat ischemia. We treat arrhythmia and sudden cardiac death that are triggered primarily by the ischemic myocardium and the ischemic milieu. And also we want to improve LV systolic function, which manifests mostly as improvement in LVEF. On a clinical level, you want to help patients feel better, less angina and less heart failure symptoms. You want to decrease heart failure hospitalization, prevent myocardial infarction, and overall improve their survival. And you kind of make an assumption that these clinical outcomes are achieved through these pathophysiological mechanisms. Has this been proven in clinical trials and at a mechanistic level? It hasn't, but the clinical discussion or the clinical outcomes have been shown in the famous STITCH-ES trial that showed in patients appropriate for CABG with evidence of LV dysfunction, CABG in addition to optimal medical therapy resulted in significant improvement in the study primary outcome, which was all-cause death, over an extended follow-up duration of 10 years, which was not initially seen in the short term. So CABG was successful in reducing all-cause death by about 15%, reduced cardiovascular death by about 20%, and also reduced heart failure hospitalization or all-cause mortality. And based on this, the guidelines reflected the advantages of revascularization in the setting of ischemic cardiomyopathy. The question comes up is, what is the role of PCI in patients with LV systolic dysfunction and ischemic cardiomyopathy? The guidelines, the American guidelines, clearly mention CABG with a class of with a level 1 recommendation, class of evidence B, that patients with stable ischemic heart disease, multivessel disease, and an EF of less than 35%, CABG is recommended to improve survival in this population. What about PCI? The American guidelines are completely silent on that. And a similar stance is taken by the European guidelines, showing that it is the first revascularization strategy in this scenario, but also they give a lower level of lower class of recommendation in patients who may be felt to be good candidates for revascularization if complete revascularization can be achieved. So with that background, we'll introduce the revived BCIS trial, which was published in New England Journal of Medicine. It's a study out of the United Kingdom. Very well done study. I congratulate the authors and investigators on this very robust trial. Who was included or eligible to be enrolled in the REVIVE trial? Patients needed to have evidence of LV dysfunction with an ejection fraction of 35% or less, documented either by 3D echo or cardiac MR within the year prior to randomization. They needed to have extensive coronary artery disease, and they used a quantitative measure that has been developed by the British Cardiac Society with a score of 6 or more. We will expand on this in a second. They also needed to have evidence of viability in 4 dysfunctional segments subtended by a vessel that is amenable to PCI. In my opinion, this is a very well defined inclusion criteria. You need to have evidence of dysfunction in an area where there is viability, in an area that is subtended by a vessel amenable to PCI. So they optimized enrollment criteria for PCI to be successful in improving the defined outcomes, as we will see. So if anything, they've stacked the cards in favor of PCI. What happened at the end, we will see. A few points to mention. Viability was adjudicated locally, i.e. by the enrolling sites, not by core lab adjudication. What is a dysfunctional segment? Anything from mildly hypokinetic to a dyskinetic segment were eligible, and they allowed all kinds of imaging modalities to be used for viability evaluation, and they developed modality-specific criteria to define viability. Who was not allowed to be in REVIVE? patients who had an MI within the last month, patients who were admitted with decompensated heart failure within 72 hours, patients who had a VT or VF event and received appropriate ICD therapy, and severe valve disease requiring imminent intervention, patients with severe advanced kidney disease unless on hemodialysis, and as always, pregnant patients were excluded, and those with a life expectancy of less than 1 year were also excluded. This is the BCIS Jeopardy score, which it's a very regimented system for evaluation of CAD severity. It starts with the left main stem. It gives you a definition for what's severe and how many points do you score. And then if you score something, where do you go to next row, and so on and so forth. And at the end, you calculate the total score, which will give you, which ranges from 0 to 12, with higher scores indicating more extensive coronary artery disease. So for example, if a patient had isolated proximal LAD, they would get a score of 6, and if they meet other enrollment criteria, they would be eligible for enrollment in this trial. Patient with an isolated left main gets a score of 8. Patients with multivessel, 3-vessel disease, such as Prox LAD, OM, Prox RCA would get a score of 12. Our patient that was presented gets a score of 8, and therefore would be also eligible for enrollment in this study. How did they define viability? Most viability study or assessment was performed via CMR, which is, in my opinion, consistent with European utilization pattern for advanced imaging. We tend to use more nuclear techniques in North America, but in Europe there is predominance of cardiac MR. What was defined as viable is less than 25% transmural late gadolinium enhancement. So the thickness has to be less than 25%. If there is thickness between 25 and 26 and 50%, there has to be other corroborating evidence, such as presence of contractile reserve and so on. In 25%, low-dose dobutamine was used, and you need to demonstrate a 2-grade improvement in the function of a dyskinetic or dysfunctional segment. And radionuclide imaging was only used in about 5%, and they allowed both SPECT and PET to be used to demonstrate viability with the criteria shown. So between August 2013 and March of 2020, there were 700 patients enrolled from 40 centers throughout the United Kingdom. Enrollment was not homogeneous. There were 7 centers that enrolled more than 20 patients each. And there were 21 centers, majority of centers enrolled less than 10 patients. And there were some centers as dedicated CTO programs, where our others were not. So this may give you an idea about what kind of complexity and how these lesions where the coronary disease was addressed by respective centers. Follow-up was completed in March of 2022 with excellent follow-up, and patients accounted for in the intention to treat in about 99%. Very, very minimal loss of follow-up. What about the criteria or the characteristics for these patients? A total of 700 patients were enrolled, as I mentioned, equally split between PCI and OMT. Mean age was about 70%. Patients were predominantly white males with high prevalence of risk factors. For example, diabetes was present in 40% of these patients. 50% had prior MI, about 5% had prior CABG, and 20% had prior PCI. Mean LVEF was 27%, so these patients had significant LV dysfunction by core lab adjudication, and they had extensive coronary disease with a median BCIS score of 10, with a range from 8 to 12. So they were, if anything, at the higher end of the spectrum in terms of anatomic severity. This is a very important point. About 3/4 of these patients had NYHA class 1 or 2, and 2/3 of them had no angina. And if you read the commentary about what was the rationale behind this, it appears that this was done by design, meaning that they did not want to enroll highly symptomatic patients from an angina standpoint that would result in a significant crossover and would bias the results to the null. So these are patients who mainly had heart failure symptoms, but not angina. And this is very important in interpreting and extrapolating the results into clinical practice. So we looked at the severity from a BCIS score. If you look at it from the phenotypes, the morphologic phenotypes, 40% had 3-vessel disease, 60% had proximal LAD disease. These patients were treated in an excellent fashion, 90% on RAS modulators, 90% on beta blockers, 50% on MRAs, and 50% received ICD. So these patients were optimally treated in every sense. What about PCI? What was done to these patients? 96.3% of these patients received the intended revascularization procedure. On a median number of vessels treated was 2, range 1 to 3, and a median number of stents was 3, predominantly drug-eluting stents. So this is a contemporary PCI trial in terms of technology use, predominantly drug-eluting stent. Interestingly, MCS use was only 3%. Support during PCI. The bleeding complications and access site complications were relatively infrequent, about 4% and 6%, and AKI happened in less than 1% of these patients. What about the primary endpoint of the trial, which was all-cause death and heart failure hospitalization? There was absolutely no difference in terms of the primary endpoint, with an event rate of 37.2% in the PCI arm and 38% in the OMT arm. And as you see, the Kaplan-Meier curves are superimposed with no difference in the primary endpoint. This graphical representation shows the secondary endpoints. If you look at all-cause death alone, there was also no difference between PCI and OMT. Heart failure hospitalization, CV death, there was numerically less events in the PCI arm, but this did not reach nominal statistical significance. There was significantly more revascularization in the in the OMT arm, which we will expand on. And the total myocardial infarction was absolutely identical in both arms. The breakdown was different, however, whereas there were twice as many spontaneous myocardial infarctions in the OMT time and the OMT arm. There were 4% peri-procedural myocardial infarctions that strictly happened in the PCI group. And also these PCI procedures came with a 5-fold increase in the rate of procedural bleeding complications. With regards to subgroup analysis, there was no heterogeneity of treatment effect, and there pre-specified subgroups, including age, extent of coronary disease, extent of LV dysfunction, other criteria. There was no difference, and we could not identify any subgroup in which PCI outperformed optimal medical therapy in this study. Device implantation is something that was interesting as we try to explain and understand the results of this trial. There were more devices implanted in the medical therapy arm compared to the PCI arm. Why is that? It's not clear. Remember, this was a strategy trial, so physicians could treat these patients up to according to their discretion and decide when an OMT is when a device is indicated And you see there was more devices implanted after enrollment in the OMT arm. Device therapy also was different at every point. So receipt of appropriate device therapy, whether it's a shock or anti-tachycardia pacing, was more prevalent in the OMT arm at 6, 12, and 24 months. Whether this is due to more arrhythmia and where the devices were successful in aborting these events is plausible, but we don't know. And how does this affect the interpretation of the results also is unknown at this point in time. What happened to the ejection fraction? This is the EF according to the core lab adjudication. 32% at baseline. The EF increased equally at 6 and 12 months in both arms, with no significant intergroup difference between OMT and PCI, meaning that both optimal medical therapy and PCI resulted in significant and comparable improvement in ejection fraction over time. So we did not see functional improvement successfully achieved in the PCI arm. There was a win for PCI in this trial, where there was early on significant improvement in quality of life using a disease-specific patient-reported outcome, the Kansas City Cardiomyopathy Questionnaire, that assesses the impact of symptoms and quality of life, with higher scores indicating perfect health status. Both groups started in the 60 score. At 6 months, there was significant improvement, with about 6.5% difference in favor of PCI. This is a medium effect size, favoring PCI over OMT. With time, however, this difference between PCI and OMT diminished, and both groups were feeling relatively well and comparably well at 24 months. Just to put things into perspective, this is equivalent on corresponding data from the STITCH trial that showed that patients were as sick as those, patients revived were as sick as those in the STITCH trial. The significant improvement seen with PCI diminished over time and revived, but there was consistent and persistent improvement in quality of life in favor of CABG, which compared to OMT in STITCH trial, and this difference did not diminish over time. This is despite the early hit that CABG patients get in terms of quality of life after prolonged hospitalization and ICU and so on. What about completeness of revascularization? There was complete revascularization was roughly achieved in about 70% of these patients, and there was no difference in the primary endpoint whether more complete revascularization was achieved or not, and the event rates were identical between both groups and with optimal medical therapy. So it's not a matter of completeness of revascularization at this point. There were, as I said, more unplanned revascularization procedures in the optimal medical therapy arm, and there was a crossover rate of about 10%. Mainly, these were PCI procedures 90% of the time. And the events or the indications for these procedures are not clear at this point, but I still think that a 10% crossover rate is not significant or is not significantly very high, and is an acceptable crossover rate in a strategy trial like this one. So in conclusion, if you look at face value for the revived BCIS trial, you can comfortably say that PCI did not offer incremental prognostic benefit beyond optimal medical therapy in patients with ischemic cardiomyopathy and evidence of hibernating myocardium. So this is the conclusion stated by the authors, and this is the conclusion from the results. What about the strengths of this trial? I think the investigators are to be congratulated. As I said, this is a highly relevant question, very pertinent to practice, and they answered it in a very rigorous design, in my opinion. They conducted a randomized controlled trial with very clear definition for viability, enrollment, target population was very carefully selected. So it's a very well done study from a methodological standpoint. What about limitations? Short follow-up duration is been cited as a potential limitation, especially when you look at the results of STITCH. I remember at ACC when the original STITCH trial was presented and it was a wash, it was a negative study, and then the extended study showed a difference in favor of CABG. Could this be the same story with PCI? We don't know. This remains to be seen. Sample size, they calculated the sample size of 700 patients based on accruing 300 events. However, they only accrued 263 events out of these. But in my opinion, this is not this is not a inadequate power type of event or a type 2 error type of situation, because the confidence interval clearly crosses the unity line, and the point estimate is exactly around 1. So this is not a matter of if the study was slightly larger, we would have seen benefit favoring PCI over OMT. This is not the case. This was an open label study by design, so it is conceivable that the benefits shown with PCI are due to placebo effect. Determination of myocardial viability was based on referring sites, and there are different levels, and whether this will hold, the conclusion and the findings will hold true when core lab accreditation data are presented remains to be seen, and these data are expected in 2023. What is the explanation for the lack of benefit seen with PCI? Follow-up duration, as I said, is a potential explanation. Some argue that these patients were not sick enough, did not have enough symptoms, did not have enough CAD. I'll be curious to hear what Dr. Nadim thinks, but in my opinion, I think these patients were very carefully selected and they had enough CAD to show benefit, but this was not the case. Crossover rate, I think it is a slightly over exaggerated in terms of importance. A 10% crossover rate is not high. A much higher crossover rate was seen in ischemia trial, for example. So a 10% is within an acceptable range, and we would have been very advantageous if we've seen the per protocol results, but only we were shown the intention to treat analysis results, not the per protocol. I think the main reason for the difference is that PCI and CABG are biologically distinctly different. PCI lends itself for treatment of focal disease, and that's why it is superior in the setting of acute coronary syndrome. When there is an issue of diffuse global reduction in myocardial flow, focal treatment may not result in the pathophysiological changes that we think would happen. But again, mechanistic studies are needed, and these are only hypotheses. This is, as I close, this is just to show you that STITCH trial and REVIVE trial were very similar. Patients were older. Yes. Is this enough to explain the null results? I personally don't think so. I think otherwise there were a lot of similarities between the two studies. What does the study not tell us? The study does not refute the benefit of revascularization in properly selected patients with ischemic cardiomyopathy. This was not a study on the benefit of viability testing, and the notion that There is no role for viability testing in the current era of ischemic cardiomyopathy management. I don't personally believe is supported by available evidence. And we'll be happy to discuss this in further details. So PCI for CAD, state of affairs in 2022, I think PCI continues to be a very important tool. It has helped a lot of my patients, a lot of my family members, to be honest. And I think the benefits are clearly in the ST elevation, myocardial infarction, and acute coronary syndrome. And the advantage is prognostic. It improves survival and reduces recurrent events. It's also beneficial in patients with stable disease for the purpose of improving quality of life if they have refractory angina despite OMT. Otherwise, the role of PCI in stable coronary artery disease does not appear to be supported by available data at this point in time. So if you look at the different scenarios of PCI for stable ischemic heart disease, stable angina, COURAGE trial was negative, did not show benefit with PCI. Berry 2D in diabetic patients, another negative study. Ischemia and ischemia CKD, the presence of ischemia did not modify the benefits from PCI. Multi-vessel disease, FAME3 was a negative study. Low EF, revived BCIS. So I think there is mounting evidence about the benefits of PCI in stable ischemic heart disease. So as I conclude, among patients with ischemic cardiomyopathy, severe CAD, and evidence of myocardial hibernation, PCI did not provide incremental benefit beyond OMT alone, at least based on the available data. However, patients who received PCI had quicker improvement in health status, a difference that dissipated and disappeared by 2 years of follow-up. Patients with LV systolic dysfunction, severe CAD, and amenable anatomy and acceptable surgical risk should be considered for CABG to improve with the intention of improving overall survival. And multidisciplinary discussions are essential in scenarios where supporting data are lacking, primarily to align the expectations with prevailing evidence and make sure that we communicate with the patients what are we trying to accomplish and what data exist to support our assertions. And lastly, PCI offers acceptable means for quicker control of angina in the contemporary practice of stable ischemic heart disease, and it is not for prevention of heart cardiovascular events. I thank you for your attention, and I look forward to input from my colleagues and for your questions. Thank you very much.
Thank you, Dr. Faraz, for presenting this trial very elegantly. Really, like you went through all the queries and all the, all the questions that comes to mind whenever you see this trial. So maybe we'll hear a little bit from Dr. Nadeem. What do you think about the trial, Dr. Nadeem? What do you think about the results of this trial? Do you think it's really because there's a difference between PCI and CABG that we had different results, or do you think there's something else that we need to consider?
Thank you for those questions, Dr. Juria. First of all, I'd like to thank you, Dr. Faraz, for the eloquent summary and the invitation to contribute today. I've got a pretty tough job defending PCI here, but I'll try my best. First of all, I'd like to just highlight some of the queries that I had about the enrollment, which you may have already covered, Dr. Faraz. Firstly, the authors claim that the participants in this study had extensive coronary artery disease. As you've highlighted, that was done using the British Cardiac Interventional Society score, and they defined a score of 6 and above as extensive CAD. So, for example, a left main coronary artery stenosis of more than 50%, as you showed, is severe. That gets a score of 8. However, if you go down the table, you will see that a dominant 70% stenosis of the proximal left circumflex also gives you a score directly of 6. So you could hypothetically have a patient with single vessel disease, RBI be proximal dominant left circumflex, which would be included in this study. Secondly, I noticed about 40% of the participants in this trial had diabetes. And I would ask, why weren't they offered CABG as opposed to PCI, according to this findings of the FREEDOM trial as before? Thirdly, how much intravascular imaging or physiology was performed on these patients? I don't know if that data is available on the supplements, which you could share with us. And because as we know, there tends to be a discordance on the angiographic stenosis that we see, and whether those stenosis are actually able to cause ischemia, and hence, you'd expect more of a benefit if they were FFR positive or IVUS severe. You touched on the different modalities used to demonstrate viability, but I just wondered why there was such a heterogeneous choice in terms of that. Probably, of course, might be because there's so many centers and whatever was available to them. Shall I go on to the results, or would you like to just clarify some of those queries for us?
Let me take a few of them so that they're still fresh in the minds of the audience. Thank you so much. I think these are very relevant points. I think if I were to put myself in the mind of the investigators when they were trying to design this study, PCI as a complementary tool, revascularization tool, in addition to CABG. So they did not want to pick the most severe patients who would clearly benefit from being served with bypass surgery. So you want to have enough coronary disease to cause ischemic cardiomyopathy that would be amenable for revascularization percutaneously. As I said, they tried to stack the cards in favor of PCI. If it was too extensive, would have said, no, this is just too much for PCI to improve. The flip side is there was probably some bystander coronary artery disease, i.e. somebody with single vessel circumflex and an EF of less than 35%. They technically, hypothetically, would have been candidates in Revived. But you and I know that revascularizing that circumflex is not necessarily going to improve the non-ischemic cardiomyopathy. So until we see the data from core lab that shows the concordance between viability, ischemia, and revascularization, I think all of these questions remain legitimate questions, but a definitive answer cannot be achieved. I don't know if I answered at least some of your questions, or if you have any other thoughts.
No, I think you've clarified some of them there. With regards to the results, you showed that the anatomical revascularization was quite high, and they used, I think, was called the anatomical revascularization index, and they said it was about 70%. To me, that would appear sort of modest, I guess, if you compare it to CABG, where you would assume that 100 would be complete revascularization. With regards to the primary outcome, obviously, numerically, it was a little bit better for PCI, but there was no statistical significance. But I would draw your attention just to the very large confidence interval with the hazard ratios, which shows that there may be, in terms of the confidence interval, a benefit of PCI as much as 22% or a harm up to 27%. That may be because, as you pointed out, the number of participants in the trial might be a little bit less than they wanted to, or they hoped to get, I guess, because it was difficult to recruit. You showed that the spontaneous MI and the unplanned revascularization was less in the PCI group. We'll take that win. And compared to the STITCH trial, as you've shown, STITCH appears to show there is a benefit with CABG in these patients. And as you pointed out, that might be because CABG offers complete revascularization as opposed to PCI, which we tackle focal stenosis. So I'd just like to put my takeaway messages just like you did. So this trial doesn't apply to ACS patients or patients with angina. This trial applies to chronic coronary syndrome patients with stable, severe LV dysfunction, where basically they have no angina. I think it also highlights to me how good medical and device therapy is now. But despite that, I noticed at the trial's conclusion, around 30% of the participants were dead. So it shows us that we've got a lot of more work to do. So how will it affect my practice? So let's, for example, take a 70-year-old male patient with severe reduction of LV systolic function. He has no angina. He's on good medical therapy. He has single severe vessel proximal major epicardial coronary artery disease, which doesn't include the left vein or LAD. Probably, as you've highlighted, PCI is not going to help that man. However, if the same man comes to me, he has chest pain on exertion, he has severe multivessel disease, including the left vein or the LAD, I would certainly consider revascularization for him and probably with CABG.
Very excellent comments, Dr. Nadeem. So for the sake of, making it more relevant to everybody, not just imagers and interventionists, how do you think we should approach someone with heart failure, so symptoms of heart failure? Should we look at and no angina? Should we look at anatomy? Should we look at ischemia in terms of imaging, or should we do both and then decide? What do you think? Do you think this trial changes the sequence that you would do things, or you would just go on with the same way of doing it by excluding coronary artery disease with an angiogram, and then, depending on the result of the angiogram, you would go for a non-invasive testing to assess for viability? So I would like to hear from both of you. So Dr. Faras, maybe you want to start?
Yeah, sure. So the scenario that you've described is a patient with heart failure. I think the first order of business is still to categorize whether they have an ischemic etiology, ischemic substrate, or non-ischemic substrate. When I say ischemic, is coronary artery disease is the underlying cause for LV dysfunction or not? And I think this can be a session on by itself. Should I go to non-invasive imaging or invasive angiography? My personal bias is a patient with newly diagnosed LV dysfunction deserves an angiogram to define whether or not they have epicardial vessels. And let's assume for the sake of this discussion that they do have evidence of epicardial disease. My philosophy or my bias is I want to further differentiate different phenotypes within the ischemic cardiomyopathy, meaning you can think of 3 patients with low EF and coronary artery disease. You have a patient presenting with acute coronary syndrome and they have stunned myocardium and low EF. Clearly, that's not a revived patient. You have a patient with a missed myocardial infarction diagnosis who presents several months or several weeks later with an infarcted area and an occluded vessel, no angina. That's another phenotype. And you have a patient with chronic ischemia on major territories who has hibernating myocardium due to chronic reduction in ischemia. I think these are 3 different patients who have 3 different management strategies pertinent to them. So the way I would approach this is define the presence of coronary artery disease, phenotype this ischemic cardiomyopathy patient as I described. If they are in the 3rd category where they benefit from revascularization, I will discuss this in an MDT fashion and say, is CABG possible? And if CABG is possible, I will definitely send them to CABG. If CABG is not possible, we have to be pragmatic and we have to try to offer our patients the best help available. But I will regulate or take down my expectation and the patient's expectations that there is no data to support that multivessel PCI in this setting is going to help. There is no promise that the LVEF is going to improve, but we're doing it until better data become available.
What about you, Dr. Nadeem? How would you approach someone like this?
I would second all of the things that you just said, Dr. Faraz. In addition, I'd probably just add, I think intravascular or invasive physiological assessments play a major factor and helps you decide and plan what to do next. Also, working in a public sector like Dr. Jury and we do in Rashid Hospital, we have a large cohort of patients who have a huge financial burden. So let's say I had a patient where the finances are limited and you've discovered severe reduction of LV systolic function, and now you've got to decide how you're going to effectively use that money to give that patient the most benefit. In that situation, you could even consider foregoing the coronary angiogram, perhaps directly going to a cardiac MRI, and then choosing perhaps device therapy or using that money for optimum medical therapy for that patient, which may give that patient more benefit.
Okay, so I just want to tell you that this session is recorded, and there was an interventionist that said, we're not going to do angiogram.
Yeah, I'm going to hear from that. I'm going to hear about that tomorrow, I know.
So another question that comes to mind. So with Revive, we always compare it to STETCH, right? But medical therapy has changed since 2016. So STETCH was published in 2016. So do you think if we redo STETCH, we'll get different results?
That's an excellent question and a very intriguing one. I don't think STITCH will be redone. If it were to be redone, I think the benefit, the difference in medical therapy, and this is my opinion, the difference in medical therapy may not be enough to diminish the treatment effect seen with CABG. This effect is robust and durable and persisted throughout the follow-up period beyond early on. So early on, there was a penalty of higher death with CABG, but then the curves became superimposed, and then there was continuous separation. I think ischemia is bad for the myocardium, needs to be addressed if possible. The question is, how do you address it? Whether medical therapy alone will take care of it, if you have an option to do revascularization, I don't know.
So, Dr. Nadeem, you mentioned the functional assessment by angiogram, doing an FFR. But all of these patients in Revive, they had functional assessment another way by checking for viability. So do you think FFR has a value on top of having viability by imaging?
I believe so, because as has been highlighted, the concordance data and with reference to where the appropriate segments revascularized is still coming, that may give us more light. There was also heterogeneity in terms of the imaging modality chosen. You guys will be able to tell me which one is the best or which one is most appropriate. But I think certainly in the cath lab, when you're doing an angiogram and deciding which is severe, which is not severe, in terms of left main, IVUS certainly gives you a lot of data. And going on from that, post-revascularization, it also gives you a lot of data. Have you done enough? Have you done the right focal lesion? Have you optimized your stent, etc.? So I think we underuse these modalities generally in the cath lab. We need to do more. I think the more we do, the better we'll get at using it. But of course, finances always plays a role in our patients. But I think we can do better with the use of FFR and IVUS.
So, Dr. Faras, you mentioned about the ways they looked at viability in the study and that there was different modalities. Can you maybe highlight a little bit to the audience how appropriate these modalities were, and do you think a change of modality would have changed the result or not?
Thank you very much. Very, very relevant question from an imager's standpoint. As I said, 3/4 of these patients received MRI. And while they give you very clear criteria and description of how they defined viable myocardium, they don't tell you, for example, whether they also did rest stress perfusion to look for ischemia, for example. If you see ischemia on a nuclear study, that is a strong evidence of viability. We don't know how the translation of scar to ischemia or the translation of LGE to ischemia in CMR. We don't know the conversion between ischemia and scar in MRI. So I would have loved to see a more clear description whether there was ischemia evaluation with CMR or not. I think echo tends to be very specific for detection of viable myocardium, but not very sensitive. The most sensitive in the multiple meta-analyses is actually radionuclide imaging, but it was only used in 5% of the patients. So I would have loved to see more details about how many of those had prior ischemic evaluation and so on.
That was really enriching discussion with both of our speakers. I think we now understand the study very well. So when it was presented in the ESC, one of the comments was that it will not change the guidelines right now, but it's thought-provoking because it makes you wonder, should I send patients for viability testing? Should I revascularize these patients or not? And a lot of it is going to end up being decided based on a team discussion. It's always better to have the imager, the interventionist, the cardiac surgeon in the room and to discuss all the matters related to the patient before deciding on the appropriate way to deal with this. So as we're ending this session, I'd like to thank both speakers. So I'd like to thank the speaker, Dr. Faras, and Dr. Nadim for his valuable input. And I would like to thank all the audience that have attended this session. And we're looking forward to the next session. Thank you very much, everybody.
Thank you so much.
Thank you, Dr. Juwaria. Thank you, Dr. Nadim. Thanks to the audience.
Thank you.